Okay. All right, so good afternoon, everyone. Today is Wednesday, May 27th, 2020. This is a special meeting with Scott Burkhart to go over our health insurance. That's Alliant, and it's our fiscal 21 budget review. Attending are Commissioners Duncan Brooks and Filios. Do we have any changes to the agenda? Hearing none, we will now turn it over to Scott Burkhart from Alliant. Thank you, Scott. Take it away.
Thank you. David Smith, are you on the line?
Yes.
Okay, do you want to take it away?
Go ahead, Dave.
Okay. You on the first slide there, 2019 to 2020 performance to budget?
Yes.
Sir.
Okay, so starting with the first slide, what we wanted to briefly hit on is how we're doing so far this year compared to the budget as it was at the beginning of the year. And we're 7 months in, and so we have to take that 2020 projected and turn that into a 7-month number and then compare that to the actual 7 months that we've been experiencing. And if you look at that, really focus on the bold, you can see that we're actually doing well compared to budget. Coming in just a little bit under the budget, which is not normal for this time of year. As you recall, in years past, when we'd focus on this, we would talk about what we had projected, and we'd usually be performing, $300,000-$400,000 worse at this point in time. But because of seasonality, we'd expect that would turn towards the end of the year. At this point in time, we're actually in a plus position, and to be honest, it's a little bit better than even that appears. And the reason for that is one of the elements that's going to impact the medical claims in this year is there was a switch last year to the contract with Regents, and part of that contract with Regents was that the administrative fees were going to go up slightly. It was about $6 per employee per month. But then we were going to get 100% access to the pharmacy rebates. And those pharmacy rebates will show up as dollars that will come in. We have not gotten the first rebate yet since that started in January of this year, and they're paid quarterly. And the first quarter ends in March, but it takes a couple months, so we should be getting that first check soon. But once we start getting those checks, they're going to have a tremendous impact on the healthcare expense. Our estimate there was about $440,000 a year in rebates, and so we haven't seen any of those yet. So we're really performing quite well. It doesn't always feel like that, especially when you're in the middle of a pandemic of sorts, but it is a launching point to really when we start talking about the projections for the coming year. And so, Scott, if you want to flip to the next slide.
All set.
Then I don't know why I was waiting for it to slip on my screen. If we look at the 2021 renewal, this is our initial projection of what we're looking at for October through September, keeping in mind that if we make actual plan design changes or rate changes, those take place in January 1st. But when we look at that 12-month period, your fiscal time frame, at the bottom we're looking at a 4.1% when we look at the total expenses of the healthcare plan. This is there's different line items in here. I'll go through some of those quickly. The administrative services, we're seeing an increase there because that admin increase we're getting for 3 months in that time frame. The October through December is a higher rate than what we had in the prior year, October through December, but then they should start to flatten out at that point. We also have an increase in the premiums and fees. If you look at those, line 8275, that really relates to some degree on the added enrollment that we get with Alliant Dental, because that's a premium and fee structure. It's a fully insured contract, and so we see that having some impact there. On the medical claims, we make some projections based on where we are now and where we expect to be based on a trend. We're using a 7% medical trend and a 10% pharmacy trend, and those generate that number. Now, the 4.2% is less than those trends, and that's because we're performing a little bit better than projected at the point that we're at right now. The dental claims, we see those actually dropping slightly in that next time frame, and then the vision claims, the same thing. There's a slight drop compared to where the projected budget was because we've been performing well in both those areas. On the other miscellaneous payments, part of what we're assuming here on the life and LTD insurance is a move to standard insurance from Unum, and that's going to save $15,000 average annually. Even though you see that cost going up, it's because we're comparing to projected and not to where the actual is right now. But in addition to that $15,000 of annual savings, they're also offsetting some of the expenses that we have associated with one of the software programs that are being used for the county. So when we add those up, we get to a 4.1% starting point, and this is usually where things would be more problematic. And what I mean by that is we have that 4.1% starting point, but then when we take into account the fact that the employee contributions don't change and that your enrollment grows historically is where we've seen that add on to the increase. And so when we look at the next page, when we take into account the employee contributions, how much they pay, and how much they offset that total expense, we see that those numbers are actually going up, and that's without increasing their contributions. And so this will be a little confusing, so I'll take a minute to explain it and then check to see if there are any questions. But when we have the 2020 projected at $1.45 million for the employee medical contributions, how much they're paying, what we're actually receiving is $1.5 million. So we're collecting more in contributions than we budgeted when we did the budget last year, and it happens with the medical and the dental and even the vision. And the reason for that is we made some pretty severe changes. And you might recall that we changed the employee contributions not just on how much they were paying and how much the spouses and children were paying, but also how much they paid if they were a smoker or non-smoker. In addition, on the dental contributions and the vision contributions, those were also increased fairly dramatically. And there was some anticipation with the increase to contributions that we would actually drop some enrollment, that we would maybe lose some spouses, that we would lose some people from some of those plans, and that really hasn't happened to a large degree. And so we are therefore collecting more than anticipated at the time that we made the changes, meaning that the changes that we made last year are actually saving more money than we anticipated. That's why we're seeing that percent change where those contributions are going up, which then helps reduce our net cost to the county. And you see that going from a 4.1% when we look at total cost to the net cost to the county increasing at 3.8%. As far as the assumptions that were made for this, we're assuming that the enrollment is flat. And that's a big driver of this because in the last 2 years, each year that we did the projection, the enrollment grew. Last year it grew from 715 to 750 employees in that projection. And so when we increase to that degree by about 5%, if we were doing that same thing this year, we'd be looking at an increase that was closer to 9%. But without any enrollment growth, we're keeping that fairly flat. Now that could still be an item up for debate, but what I tell you is with COVID, I've not done a single projection where anyone is anticipating more enrollment in the coming year. Generally speaking, they're looking at the same enrollment, if not less. So any questions on the initial projection at this point before I move on to the next slide?
Sounds good. Keep going.
Okay, next slide. So one of the items that's going to have an impact, and then, a question you should have is does this account for any potential impacts of COVID and what have we been doing related to that? And not everyone here is involved in every meeting that we have with HR or finance when we discuss these items as to what we're looking at. But with COVID specifically, we've had several discussions on the COVID impact and looked at different potential scenarios. And so this is just a screenshot of the model to give you an idea of kind of where our discussions have gone. We've modeled anywhere from 5% of the members get it to 2%, as high as 30% of people get COVID at the county. Now, there's varying degrees of likelihood of those, but one of the things that we found was fairly consistent was when you have a more severe epidemic, your scenarios change to where the simple fact is your cost does not go up by that much. So a hospitalization for COVID is expensive and will be expensive. And the testing, while not that expensive, if it's done to a high degree, it could grow in cost if it's not offset by some other, government entity. But if an epidemic grows more severe in a specific area, if we were to have a cluster, the shutdowns in different places. Spokane is just coming out of one. You guys have been out of one for a little bit. During those time frames, the elective services on the dental, the vision, and on the medical, they aren't happening. And when they don't happen, the claims cost goes down. And to a pretty significant degree, about 50% to 60% of claims cost, of medical claims cost, are considered elective. It doesn't mean people can choose them, but it really means people can choose when they have them, and about 10% of those are claims that could just go away completely. If we're in a scenario where we have a large cluster and we were to shut down and those things occur, then the claims that we offset, claims that don't occur anymore, largely offset the extra cost that we might get if some of our employees get the disease or if some of their dependents get the disease. One of the things that we've been tracking with our entire population, we look at, and one of the things I look at distinctly that I can see right now, because I've not seen a hospitalization in the claims data for any of the groups I work on yet. I have seen testing, and I've seen testing, I think about 210 tests, which is not that many for all the groups that I work on. Of those 210, about 120 of those were for first responders. So those were for fire, police, and then emergency physicians and the like. And so, with our employee base having about half of those be first responders, but the reality is the population that we're covering, that we consult on now, have direct access to in that degree, first responders make up about 2% of the total, so about 2% of total making up 50% of the tests. So we don't have a lot of testing going on in our groups outside of those first responders. The testing is coming in at that $75 estimated testing price. So we feel pretty comfortable with the modeling where we've been. Giving an idea of what our thoughts were on that is that, it could potentially, cost up to $184,000 more in your healthcare spend over time than what you normally had, if we set this at a 5%, but that'd be spread out over not just this year, but also, the coming year. So it's really not necessarily going to cause tremendous pain unless, we had a major event here like they have had in some places. And, what I can say about that from a mismanagement perspective is that it's good to follow recommendations to try to maintain distance, to give an opportunity that you don't have a breakout in an area, because the places that we have seen those in the country, like the meat packing plants or the pasta plant here in Spokane, are when people are in a close proximity for an extended period of time, where it transmits fairly easily. And so if we can minimize that, I think it really mitigates what the impact could be. Quite frankly, the biggest impact, and we've had several discussions with all kinds of different kinds of clients on this, is not on the cost side, it's on the revenue side, and that would be true of you as well. That would be the thing that's most concerning, is that the revenue, tax revenue, different pieces of income go down, and that creates its own sorts of problems. And so that's really what we'd say, would be a good place for you to focus on and not worry too much about the healthcare side of the cost. Moving on to the next slide, I'll hand it off to Scott to talk about the standard and the plan source offset.
Yeah, thanks, David. As David mentioned, so we had an opportunity to make a change to standard. We had some administrative difficulties with Unum over the last couple of years. They changed their service model, and when we converted to plan source, there was just a number of issues. So we worked with standard, came up with a 10% discount on the life and LTD, the basic coverages, which the county pays for. It amounts to about $15,000, so not a huge number, but a nice percentage decrease. Well, they also threw in 47% savings on the plan source fees on an annual basis. Now, we're only going to see 9 months of those, but that saves another $17,000. So the total savings with standard would be about $32,000 with minimal employee disruption. It's just an automatic conversion. Within the plan source system, when we were with Unum, they would have employees go outside the plan source system, we start inside plan source and then go out into the Unum system to elect voluntary coverage. Well, Standard's going to work with plan source now. They've already built modules. It'll just plug right into plan source. So the employee stays within plan source, and that will be the one source of truth, which will minimize 90% of all the administrative difficulties that we had. In addition, Standard has local service team right here at a Spokane, so we will have greatly improved service with Standard. And I think it's unanimous from HR that yes, we would really like to make that change to Standard. So there's on the voluntary coverages, there's a number of different dynamics, and we've walked through them with HR, but there's only a handful of employees that are impacted, not in a negative way, it's just going to be different. In other words, like on the short-term disability, Standard offers vastly more coverage, so the total cost is a little more, but when you look at the actual incremental cost, it's less on all age bands. So just little quirks like that, which we can easily walk through and communicate to employees when it comes time. So we also got word from Delta Dental that there will be no admin rate increase with a 2-year rate guarantee. VSP also offered the same, no admin rate increase, 2-year rate guarantee, and Alliant will offer the same, no rate increase with a 2-year rate guarantee. And that'll make, with Alliant, that'll make at the end 5 years with no change in rates. So we're kind of proud of that. So now we've kind of talked through all this, and when it comes to recommendations for what to do, we just wanted to start with this, and we'll kind of back into it. We've got some reference points to what we did last year with benefits, contributions, and we've got some benchmark references. But initially, we'd kind of like to start out with this. With COVID, with the uncertainty with employees, and with a 3.8% net cost to the county projected increase, we'd like to recommend that the fewer changes to make this year, the better. And so plan design, we're not recommending any changes at this point. Changes to employee contributions, we're not recommending any changes at this point. Now, that being said, we understand that there's a lot of unknowns with budgets, with revenues, with all that, and so subject to need to do something, we're recommending not. And as we've talked with Sylvia, in terms of total compensation for employees, the benefit to make a modest deductible change or an employee contribution change, that's not where the big savings are going to come from. So this could be perceptive-wise a big win if we don't have to make any changes this year. Okay. So what we will continue to work on behind the scenes, we'll make sure all the core fundamentals of the benefit plan, the cost pieces, are the most competitive that we can get.
Can you guys mute yourself if you're not talking, please?
Yeah.
Thank you.
Thank you. So, and those fundamentals, 85, 90% of your budget's driven by the provider network on the medical plan. Are we getting the most competitive discounts? And is there a more competitive limited network out there? Not now, and especially not now with COVID. Would we want to entertain anything like that this year? So, most of your savings with Regents on the provider side, we're getting the best discounts. We'll make sure stop loss is the most competitive. All the various components like that. One thing we will explore as we go forward is a potential change to the pharmacy benefit manager. I'm not recommending that we do change, but we can pull out the pharmacy benefit component from Regents, and it's minimal disruption to employees. Regents could remain as our administrator overall and just plug in a different PBM like Costco. We're seeing 1% to 2% overall cost savings with that in terms of the total plan cost. So if we need to get that 3.8 down to 2.8 or 2.5 or even less, there's a modest step we could look at pretty seriously and without impacting the employees. So we'll get the actual numbers for you on that as we go forward. We talked last year, the last couple of years, about implementing a health savings account or a consumer-driven account. And we'll continue those talks. This year, again, would not be the year to implement that. So we're kind of putting that on hold. But we'll continue to work with HR and finance on those things. Just a reminder, last year, we won't spend a lot of time, just as a point of reference for the changes that we did make last year. David mentioned the major rebate and RX savings that we'll experience in the numbers with Regents. We increased the employee out-of-pocket max $250. We had modest medical contributions to employees, and probably one of the bigger changes that was made was change the dental contributions to where employees were paying 30%. Now they're paying about half the cost of that. So for just rephrasing that from a visual standpoint, this is what it looked like last year, going from 19 to 20. No change to deductible, but the out-of-pocket maximum did change, $250 for an individual, $500 for a family. And then the employee contributions, just a $5 change to the employees, but a $20 change to spouses. That was the big impact that we had last year. And this slide it's in the presentation, so you can reference this at any time. Just want to talk about benchmarks real quick. So this is just a snapshot of where you are relative to other public entities. In the past, we've looked locally as well as nationally. From a total cost standpoint, this is more what the total plan cost is. This is just showing that the county benefit plan, even though we've had, some large claims over the past couple of years and, some decent trend increases, the county plan is still in a very competitive cost relative to the benchmark. The county's total funding rate is $565 per employee. The benchmark would be about $700. On a family side, it's pretty close, but overall, this shows that the county's in really good shape in terms of total plan cost. Employee contributions are less than the norm, okay? When local is about $70 on a single employee rate, where it's nationally, if you look at Kaiser and Mercer nationally, it's about $110, so you're about half that. And on the family, you're lower. The deductible is the other main metric that we look at. The county's at $600, and the benchmark would be about $1,100, okay? So all that to say is the county benefit plan is in really good shape. This is not, we wouldn't say license to, hey, we've got room to increase, because again, when we look at total compensation, we got to factor that in too. But this is a really good, we're in a really good situation right now. And then this is just a reference point of what the actual contributions are. So I've got more detail in the presentation of what those standard versus Unum differences are, but we won't go into those. We've gone through those with HR and finance. And that's all we have for a formal presentation. Now we'd like to ask you, where would you like to go next? We could expand on COVID. We can talk about other potential changes or whatever you'd like to talk about. So.
Thoughts?
My only thing, and it's obviously not relevant because we won't go there, but just how would we implement an HSA going forward and kind of what those steps would look like, but we can wait till next year.
Yeah. Okay.
Bill?
I'm in what I consider to be a year that's going to be an austerity budget. We just have to flatten our own curve, if you will. We really do, because we don't know what's to come.
Right.
And I know I've talked to some people at Kootenai who they have gone exclusively to preferred provider and been rather draconian about that. Is that anything that would benefit us?
Yeah, I actually, we have Coco Braukoff here, who was formerly at Kootenai Health HR, part of that change. So do you want to comment at all on the limited network? Do you want to come over here to the mic? Yeah. And then I'll follow up with Coco.
Sure.
So Kootenai Health did go to a directed network a couple years ago when I was there, and They did have some employee feedback, not always positive. It definitely did limit the network a bit. The providers in the area weren't thrilled about it either. But I think over the last couple of years, they've really worked through that process. It's still a very large network. It does eliminate some hospitals in the area. And not necessarily that you guys would need to do that here at the county, but that's what Kootenai decided to do. But yeah, I think it took a couple years to get through the process, but again, the network remained probably about 90% of what it was before. So you did have some employees that were disrupted, but.
My understanding is if you have to go to a hospital in the valley or in Spokane to get something that was not available from a practitioner here in Kootenai County, you wouldn't be precluded, but it would be examined carefully.
That's
Is that
correct,
accurate?
yes. Through the Kootenai Care Network, you could request the approval to go to a Spokane hospital.
Right, or
but it-
Seattle.
Or Seattle.
Or whatever.
But it had to be something that was not available within the Kootenai Health Network.
And how much did that really reduce the, in their case,
You know,
not in our case,
Yeah, I
in their
don't,
case?
I think it was more about increasing revenue than decreasing
Oh,
cost,
okay, well,
paying themselves.
Not surprising.
And I can comment on that too.
Yeah.
David and I can.
Yeah.
Yeah, good job, Coco. Thank you.
Thanks.
thank you
Bob.
very much.
Appreciate it.
Yeah, David, can you talk about, in just a sec, limited network and kind of what your thoughts are with that? But if we're, where the hospital is their own revenues going internal, what we typically see on a limited network is potentially 10, 20% savings on a plan. That's what we'd want to shoot for at least, to where it even made sense. Now, that's a big number, right? But it could potentially be huge disruption as well. To get those savings, you have to have disruption. I mean, there has to be that trade-off there. So, David, do you have other thoughts with that?
Well, I mean, one thing I will say, and we haven't talked about this, I think we skipped by it in one of the other slides, is we've been in the process of the last 3 months integrating Kootenai County data with our IDAP system, which is our claims analytical system, which helps us to do a lot more in depth of the work that we do. And some of that it contains in there is access to the Quantros tool. And Quantros is a tool that measures provider efficiency and provider quality, patient satisfaction for different areas based on national guidelines, and compares how your people are using the plan in conjunction with that. So are compared to what you have available in the area, are you maximizing your usage? Are you not maximizing your usage? And we'll have that in place fully the middle of next month. And so we can do a comprehensive analysis at that point in time as to what the opportunity is. What I will tell you is that for us in the inland northwest, our opportunity tends to be a little bit lower than people in more dense areas where they have 5, 6, 7 hospital systems as a choice because of the competition that they have there. They tend to also have high-priced providers that they can save a lot of money on. Our costs in the inland northwest is relatively low compared to a lot of areas, and so it's really quite a bit harder to get that much lower. In addition, we do know from our historical context is that your people use Kootenai system more than what else is available in Spokane and also locally with the other minor hospital. And we know that the Kootenai is a little bit more expensive than what you have in Kootenai County, but it's less expensive than what exists in Spokane. But it's also the highest quality hospital in the region on those measures. And so it's really going to be more about finding specific areas of usage, not necessarily you should send everyone to this hospital or that hospital, but that there's a category here. It might be surgeries that can happen in an ambulatory clinic setting, meaning instead of going outpatient hospital, they go to really an office where they can do these same surgeries. be finding more opportunities like that and trying to steer those, which again isn't going to be like the huge savings that you might hear about from someone who comes with a larger study, but they are what the savings we will probably have better access to. So I know that was probably a little bit more talking than was anticipated out of me, but that's what we're expecting to see, and we'll be able to quantify it pretty strongly at that point, about a month and a half from now.
And just to clarify, David probably passed out when I threw out a number of 20% savings off the cuff. So David, just relax, just off the cuff. But that probably is a high number. I mean, if we're looking at savings realistically, it's probably 5 to 10% that we'd be targeting, maybe not 20. That's probably a little aggressive, but it's got to be worthwhile.
Save 10 and I'll be happy.
Yeah, it's got to be worthwhile, but in order to make it worthwhile, there's going to be some employee disruption. And to David's point, when we look at your utilization, we'll look closer at it, but when we looked at it last year, most of the people were using Kootenai to start with. So what is their motivation to offer additional savings when all the people are currently, or not all, but many of the people are currently using them? So that's really, but we'll explore, continue.
So far, so good. Did you guys want to go any deeper?
I'm good.
Well, one of the things that came up this morning with this individual I talked to from Kootenai was he said, I got kids, and we were in the habit of taking the kids into the ER every time something happened. He said, now we dare not, because if we go to the ER, we've got a $200 deductible. Mm-hmm. We take them to the urgent care, and we have a $50 deductible. Things like that. I mean, disruption, yeah, but it's nice to have health insurance, and it's nice not to have it at the expense of a proper, not a raise, but at least keeping up with inflation, consumer price index, stuff like that, and not slide backwards there. You give somebody a 3% raise and you take away 4 on health insurance, you're not helping them in reality.
Well, and when we talk about employee disruption, I think people need to realize that the ER should be the choice, if you will, last resort. Okay, and you go to your primary physician, or as Bill pointed out, you go to urgent care. So is that really disruption, or is that just basically having a more educated populace that knows that the ER is a last resort?
Changing behaviors.
Yeah. And that's, David, can you comment on that real quick? Because it ties in with the emergence of telehealth, especially during COVID, which we're going to see. Now people are more comfortable with it, familiar with it. And David, what are your thoughts on the ER copays and look at it, manipulating that? But part of it is just general communication to employees as well.
Right. Well, I mean, this is a big subject, so I'll try not to go on one of my long diatribes like I tend to. But there's a lot of different ways you can steer what people do, and people are getting to the point where it used to be they wanted to fight you every step of the way, but because of the things that are happening, they're going to start asking for help. And what I'm referring to, what Scott mentioned there with telehealth, there is a direction that the whole medical environment is moving, and this has accelerated it. Okay, we're already aware that there's a lot of primary care shortages, primary care doc shortages. That's been across the country because a lot of docs now, when they go to medical school, they go in to be a specialist because a specialist makes a little bit more money, and not too many people are going into primary care. And so we've been fighting that shortage for a while. And that's some of the reason that people might go to the ER or urgent care instead of going to the primary care doctor, because it's just hard to get in. Now with COVID, and we have the advent of telehealth, and not just, it was on the edges. You had a couple companies that led the charge in telehealth, but you had a lot of others that were sitting in the wings waiting to see what they wanted to do. You have companies like 98.6 that do text to doc kind of thing, and they've also been on the edges. But with this, there's been a huge movement towards telehealth to the point where, it used to be, you'd wait 30 seconds, and now you might wait an hour because they're trying to hire enough people to do it, and more doctors want to do that. A lot more primary care physicians are looking at that because it's quite frankly an easier job. You don't take your work home with you. You don't have to run your own business like you have to do sometimes as a primary care physician and worry about those business aspects. You get an Uber driver when you're working, and then you're not. And so it's a quality of life change, as are urgent cares, which are growing in number because of that. And that is going to grow that primary care shortage. As people can't get access to primary care the same way, they're going to lean towards the digital or the telehealth, or they're going to lean towards going to an emergency room or urgent care. And so there's going to be a lot more need for steerage, but also helping people find their way in a system that increasingly gives them less steerage and less frontline options. And so, the plan design can do that, but I think one of the things that we're going to see popping up more and more as we move forward are going to be the instances of concierge care where people will voluntarily be directed to places to go. And that's where certain controls can come into place to really send them to high-quality providers that maintain that cost. At the same time, when you look at the highest expenses as far as, needing a surgery or hospitalization, the concierge care helps with that greatly, but plan design then ceases to help steer, because if I'm going to have a $50,000 surgery, and it might be $50,000 at one place or $60,000 at another, my plan design, I'm going to hit my out-of-pocket maximum no matter what. So there's no cost difference in that choice. I think one of the things that we might see in reaction to that, aligned with some of these other things like the concierge care moving forward in the future, and I'm talking 2 years out, 3 years out, is that we could see situations where companies start moving a little bit more back towards some copay plans where they can really say, if you get the surgery here, it's $2,000 copay, and if you get the surgery at the preferred location, it's a $50 or $100 or $500 copay. A huge difference there, so that there's still a big difference in that person's mind as to what the cost is to them. It helps them make the best choice as to what the cost is in general. So a lot of information there. A lot of that information was 2 years out, 3 years out. But I think it's important to relay, because if you understand that the direction stuff is probably going to go, when we make decisions moving forward on certain things, we don't want to make decisions that we have to pull back from a year or two later when the market moves without us being prepared for it.
Okay, thank you, Dave.
All right.
Just
John, go ahead.
Yeah, just to piggyback on that real quick is, when we incorporated the cost modeler a couple years ago, that allowed employees to actually look at what the estimated cost would be at Kootenai Health, at Northwest Specialty, at Spokane Hospitals. Obviously, we had very few employees that utilized it, but one of the things that highlighted is it's not as if it would be in our best interest just to pick one limited network and go with them and tie into one health system, because there were different services at each location, where some were lower cost over here, some were lower cost here. So we can almost, to David's point, over time and through data, we can almost build and incent the behaviors through the copays and deductibles and create our own network, so to speak, within the plan without alienating certain, providers either, or that are the better choices. So we'll keep looking at that for sure.
I think we're good.
I'm good.
It's good news. It's great news, actually, so thank you. And Scott, Coco, Dave, and forgive me, Coco, I forgot to introduce you, and Dave, but welcome just the same. We really appreciate your being here. Public comment. Yes, Clerk Brannon, please.
I would like to state on the record that your savings switching on the voluntary products to standard from Unum is understated, because literally it has been very hard for our team to work with. So thank you, and you're going to verify that standard will be a lot better to work with, correct?
I can promise you that, yes.
Thank you, Scott.
Thank you. Yes, thank you. I'll leave it at that, thank you.
Anybody else? Now, it did indicate an action item. Are we, I don't know that you wanted us to take a vote on anything today, do it? It
Well,
would be
probably
premature
if
at
we
this
were-
point?
Yeah, if we were gonna change something or, but,
Yeah, we have another meeting in July. But if you were wanting, Scott to brief in David and Coco to review some other options for us, that's where we would get to.
Well, and Scott said he was going to bring some more information forward.
Dan, can you mute, please?
So much for that suggestion.
Hopefully that wasn't David, right? That was awesome. That was
I'm
hilarious.
sure we captured that, didn't we? Okay.
Oh my gosh.
County goes rogue.
Following that, we do have a number of, plan design options modeled, but what will be, we're not recommending making any changes. What we will follow up with is more detail on the pharmacy benefit manager cost analysis, and, stop loss and all the various components. If anything radically changes there, we'll let you know. So.
Okay, sounds good. So I think it's fair to say we have a general consensus that we're satisfied with the information that Scott and company have presented, and far better than what we expected, so.
Great.
We do truly appreciate it. Any further comments? None, okay. 1:44, meeting adjourned. Thank you, everyone.